Okay. All right. So to finish up, as you can tell, I have a very, very bad voice right now. And so I've just decided to record something rather than go through this whole thing in class. I'm going to try to get this done in about 15 minutes or so. I'm going to go as quickly as possible, covering the last few of the disorders. So, last couple, hold on. Last couple of disorders: somatic symptom and related disorders, dissociative disorders, and eating disorders. So, somatic symptom and related disorders are a group of disorders that involve having or perceiving some sort of physical symptoms where there's no actual medical cause for these symptoms, or excessive worrying about very, very minor symptoms. So, somatic symptom disorder, what used to be called somatoform disorder, is where there are somewhat minor physical symptoms, or somatic. Physical or somatic symptoms are body symptoms that cause extreme distress. So they may have mild nausea or a little bit of vomiting, maybe some pain. And along with these, there is distress over these symptoms to the point that it has an impact on their life. They may have disproportionate or persistent thoughts or worry about the severity of the symptoms, excessive anxiety about it, excessive time or energy devoted to these symptoms. And sometimes these symptoms will be very, very mild. Sometimes they will be a little bit more excessive, predominant pain or whatnot. But it is the excessiveness of the thoughts, feelings, or worry about these physical symptoms that makes it have the impact on their life. Conversion disorder is a disorder that is somewhat similar to this, where a patient has physical symptoms such as paralysis, blindness, etc., might be seizures, whatnot, that are not compatible with any sort of medical or neurological disorder, meaning they are basically having physical symptoms that have no physical cause. The assumption about conversion disorder, the reason why it's called conversion disorder, or it's also called functional neurological symptom disorder, is it is the conversion of anxiety into physical symptoms. These were much, much more common back in Freudian times. They are not. This is not necessarily all that common anymore. But for instance, here is an example. Okay, I don't know why I have two slides for this. So, specific physical symptoms in which no medical or neurological cause is apparent. This is very, very rare. It's very Freudian. Here's an example, though. This is a woman who has conversion disorder, where she has seizures that do not have any medical cause. Okay. All right. So there you go. That is conversion disorder. So, all right. Somatic symptom disorder, conversion disorder. All right. And then finally, illness anxiety disorder. Illness anxiety disorder used to be known as hypochondriasis. People who had it called hypochondriacs. Um, People with illness anxiety disorder have a very, very high level of anxiety regarding their health. They have a preoccupation with having or acquiring a serious illness. Although no symptoms might be present, or they might interpret normal physical symptoms as of a more serious disease. Okay, somebody with hypochondriasis might get like might get a headache and assume that the headache is a brain tumor. Okay, or that the fact that they have a sore throat is throat cancer. Okay, or like a freckle is they assume that a freckle is skin cancer. Okay, so it interpreting normal physical things or nothing at all as evidence of having a serious illness. So, those are the three different somatic symptom and related disorders. Dissociative disorders. Dissociative disorders are a very, very rare and controversial category of disorder in which a person reports um, experiencing dissociation, okay, which is essentially a split from consciousness. Okay, and hold on one sec. Um, where their conscious awareness, their conscious experience dissociates from painful memories, thoughts, and or feelings. Um, a lot of the time with these dissociative disorders, there's a loss of memory. Right, there is, which is amnesia. There may be a loss of identity. When they have experienced this dissociation, they may experience a loss of identity, what is called a fugue. Um, but these are very, very controversial because the belief is that they often happen in response to stress or trauma, sexual abuse at a young age or whatnot. But they do assume the existence of repression, and they are also relatively new or new to psychological science. Dissociation itself is not particularly rare. Dissociation itself, basically feeling separated from oneself, is relatively common, but dissociative disorders are exceptionally rare because they often involve a loss of memory where there is no actual physical cause. So the most common or the most commonly known is dissociative identity disorder, which is where a person develops two or more distinct identities that seem to control their behavior at different times. This used to be known as multiple personality disorder. The idea here is there's often a history of childhood trauma, and they create these multiple personalities basically as protection. Um, they may not be aware of the existence of multiple personalities. And oftentimes, at least one of these personalities is a child. The idea there is that they create a childlike personality, one that might be able to hold on to the memories of being physically or sexually abused as a child. So the reason why, so you all can watch this video on your own. Um, the reason why this is so controversial is because, all right, a lot of times sometimes the personalities just seem to be more extreme versions of the individual. People with DID tend to be easily fantasy prone. They are easily hypnotized. They are oftentimes very suggestible, even by a therapist. This has a very short history. This really didn't rise to prominence until the 1950s. There's a movie that came out called The Three Faces of Eve. And then following that, a movie called Sybil, in which it came out later that this woman who the therapist claimed had multiple different personalities, they were essentially created by the therapist through the suggestion of the therapist. The other question is, this might just be a defense mechanism as a response to anxiety. They may simply create these and be aware of the multiple different personalities as a way to protect themselves from anxiety. And I've got to finish. All right. Lastly, eating disorders. Okay, I know that you all learn about these in health class. So anorexia nervosa, anorexia was where a person, usually most of these are either younger women or gay men, will go on a starvation diet. And although they are significantly underweight, this is often accompanied by some sort of binging, some sort of extra weight loss method, such as exercise. Bulimia is where there's binge eating. A lot of times it is high calorie binge eating followed by weight loss behavior, purging, such as using laxatives, vomiting, or excessive exercise. And then there's just binge eating disorder, which is where there's binge eating followed by excessive guilt or distress. Understanding these generally come out of low self-evaluation, perfectionism, being concerned with others' perception. There are cultural components, cultures that value being very, very skinny. These are more common. Dissatisfaction with the body, as I said, most common among women and gay men. There is a high probability of improvement after diagnosis, with 2 in 3 who are diagnosed eventually getting better. Okay. All right. That is as quick as I could go through those. I apologize for my voice. Okay. All right. There you go.